Okay, well now it's my real pleasure to introduce the final keynote, and we have two presenters for this. So firstly we have Dr. Tana Fishman, who is a GP and Clinical Director for Alliance Health Plus. And Tana set up Greenstone Family Clinic with Professor Bruce Arrell back in 2006. So Greenstone is an amazing clinic based in Manurewa in Auckland, and they have a very high needs population. And then Devika is a primary care nurse who has been working at Greenstone for the last 11 years and has been really instrumental in really improving their long-term conditions and diabetes outcomes. And they have recently, were the #1 in counties for their outcomes for diabetes for both Māori and Pacific. So that's a huge achievement for a really high needs practice. So that's why we thought it'd be really valuable to hear about what are the things that they've done differently to enable them to achieve such amazing outcomes. So welcome. If we can just go welcome.
I'm going to say shalom, kia ora, namaste, ni hao, ola, talafalava. Have I missed any?
Bula vinaka.
And a big hello from an American from 20 years in the country. This presentation is in 3 parts. The long, important part is Nurse Devika. The small and less important part is Tana. And the third part is just a bold message. So I hand over to you.
Bula vinaka, kia ora, everyone. We'll try and keep it short. We know we all want to go back home. So a bit of, where's our, sorry. My introduction, a brief one. I'm born in Fiji, grew up in Fiji, graduated in Fiji with a diploma in nursing, and did my bachelor's from Central Queensland University, long distance. Moved to New Zealand in 2006. Worked in primary care sector before joining Greenstone in 2009, that was when I found out they were looking for a nurse to start or set up and lead long-term condition management. I'm currently still working at Greenstone as a nurse lead for long-term condition management, mainly diabetes, and also a nurse leader. We just don't have nurse lead a program for diabetes. We do a total of 10 different nurse lead programs for different conditions. I've also done a postgraduate diploma with a lot of struggle from University of Auckland in 2010. Haven't done any prescribing yet. So we thought to set the scene, we'll just share a case study which just happened last week. This is a 63-year-old Samoan female patient who has a medical history of recent progression of T-cell lymphoma, and she's currently under hematology and treatment. She also has hypertension, renal failure. Newly diagnosed diabetes, which we did before last week, and it's steroid-induced diabetes. What happened before we diagnosed her? She already had made an appointment with one of the doctors on a Monday. That was last week Monday, through Manage My Health portal, with complaints of blurry vision. Before patient came into the clinic, I have a responsibility of going through all the appointments in the morning and screen out for opportunistic screenings for our patients when they're actually there. And also in my inbox was sitting the HbA1c result, which was 94. The last 4 years, it had been absolutely normal, below 40. So I went and had a quick chat to the GP that morning, alerted the GP that this patient is coming to see you, and this is the HbA1c. So the GP saw the patient, broke the news to the patient. She was alone, and she's already going through quite a lot with her recurrent diagnosis and all the medications. And actually, she came in with the thought that the medications might be causing it, and she needs to reduce her medication, some of her medications. So the GP broke the news to the patient, got me in for warm handover. I had a quick introduction. Luckily, I knew the patient from beforehand, and she knew me because I had seen her for pre-diabetes in 2010 or something, and since then she was really doing well. So she wanted to come back the following day with her daughter-in-law. So we made her an appointment, and that also gave me the time to look through the case. So, sorry, I'm bad at this. This is the overall action we did with the time. So basically, the patient went away. I went away back to my room in my few empty slots, studied the medical history, medication chart, and went back to the GP and discussed my plan. Next morning, I found endocrinologist, diabetes specialist at Middlemore, who is very willing to take our phone calls. So we made a plan, and I had an appointment with the patient. Initially, we had booked 1 hour. But upon discussing and studying her file, I knew this patient would need insulin initiation, unfortunately, because it is drug-induced, and it was her BSL the day prior was 28. So I was ready with a plan. But of course, this patient doesn't know she has a diabetes. That's a big thing to break out, to break to her, go through the physiology, and then offer her insulin or tell her that would be the only kind of treatment that would work, because she had all the symptoms. She had polydipsia, polyuria, polyphagia, tiredness, blurry vision. Luckily, her ketones was negative, and her potassium was normal in terms of ketoacidosis. So that consult extended to 2 hours and more, because of course, if you are offering insulin, you've got to have the patient understand what's happening. So explaining the physiology, going through the whole diagnosis, complication, what is that, and trying to get the the blame game away from her that this is drug-induced. She is on prednisone. She has been on prednisone 5 milligram once daily. And her daughter-in-law was there, very supportive, very understanding. So I guess one of the, like we have talked about today, how we make patients feel that they are responsible, we make them feel, uncomfortable with those kind of actions or words we use. So that was, I think, one of the plus points that I could blame it on the medication. So she's got this hope that once her prednisone dose comes down, that it will come down, which it likely will. So anyway, so we spent about 2 hours over in doing the whole education session, insulin initiation, gave her the first dose. Her reading on the following day was high on the meter, so we did all the ketoacidosis screening and spoke to the specialist, and they were happy for us to manage this patient in primary care. And then I did a follow-up consult over phone the following day. We had a plan for review in that Friday, it's 4 days after, for 30 minutes, to basically go through what she had taken home, how the insulin administration went, and if there was any concern, check the sites, and all the basics of insulin initiation. So there is a summary of total time we spent with patient from the time of knowing the HbA1c of 94 on a Monday till that Friday afternoon in a week. Current funding in counties is $133 GST inclusive for insulin initiation and 2 follow-up visits. I will let you all do the maths around that. Going on from the case study, so now a bit of clinical overview of our clinic where I work, Greenstone Family Clinic. It's in Manierewa, South Auckland. It's a VLCA clinic. 53% of our patients are high needs. Of this, 24% Maori, 13% Pacific, and 16% non-Maori and Pacific. Our staffing, this is current staffing. We have GP, general practitioners, 3.2. That includes 0.8 of our vocational registrar who come in every 6 months from the university for training. NP, we have one-time FTE. We have 3 who make up to one full-time equivalent. 2 of the nurse practitioners we have, they came to Greenstone as new graduate nurses, and from there, then their journey to nurse practitioner. Greenstone has a strong vision in recognizing the strengths and skills of their employees and helping them grow. And we have nurses, 4.4 FTE, and 1 HCA. In terms of our population for diabetes, I'm sorry, I'm taking my mobile out because I have one of my second-year nurses who is very good at IT, and together we have been doing some work in getting some good in-time data for diabetes. So at lunchtime, I messaged him if I could get up-to-date hot-off-the-press data in comparison to this. So sorry, I'm just using my mobile here. So we have 355 diagnosed patients with diabetes, includes few type 1s there. And we also have 285 pre-diabetics on our list. 54% female, 46% male, 23% Maori patients. Their population HbA1c average is 61.5. We have 20% Pacific. Their HbA1c average is 65.8. We have 20% Asian. Their HbA1c average is 57. We have 7% Indian. Their HbA1c average is 59. And we have 30% European population. Their HbA1c average is 59. In terms of clinical data, more clinical data, we have 6 patients with a HbA1c of over 100. I can give all 6 patients history and social history and everything, but that will take a little bit of time, so we'll leave it at that. We still have 7 patients with no HbA1c in the last 12 months, so that's 2% of our population. We have 23% of our patients on insulin. We have 83% of our population up to date with photo screening. Another 5% are overdue because there is a huge delay with ophthalmology appointments in counties. We have 85% up to date with the foot checks. So how my journey started at Greenstone in 2009, I did not know much, but I had a vision because I have grown up and seen my mom with complications of diabetes. And unfortunately, I lost her 2 months ago. So I have a strong passion around working with Pacific population, Maori population, and a high needs population where the health literacy is low, to help them prevent coming to these complications. And that's how our journey began. We have done lots of PDSAs. Like I said, there was no model in New Zealand which has been applied or which we knew. There has been lots of nurse-led clinics overseas, UK, and I've read about date population health, and based on that we started. The enablers of nurse-led care. The first and the foremost enablers are my employers, my bosses, and that is the doctors. They had very clear expectations and also very supportive. And we have a very horizontal structure. We do not have hierarchical structure at Greenstone. So I can go and tell of my doctor if they have missed a foot check or if they have not done a warm handover. How many of us nurses can do that? And Tana is one of them. Tana has been one of my mentors, and she has taught me a lot, and we have believed at Greenstone, and I guess that's what's given me the confidence to lead this, is we believe in this skill set. Yes, qualifications are important, but sometimes it's also, the balance has to be right. Like I said, I am not yet a prescriber or a nurse practitioner. I might get there one day, I'm not sure. So the enablers for nurse-led care at Greenstone, teamwork is the key. Now this is one of the biggest barriers also, if not done or overcome. Because this initial barrier is lack of understanding amongst the whole team. And the good thing at Greenstone is we do 2 weekly peer reviews where we discuss everything what happens at Greenstone or the important topics and the priorities. And we also try and communicate that with reception and the whole team. The other important thing we do is we believe in standardized care. So whether you are a new GP, new doctor, new nurse, or part-time locum, once we have discussed in peer review, yes, we want to go ahead and do this program this way, we all must agree and do that way. Rather than we be in peer review and then you go out of the room and do things your own way. And I think I'm repeating myself. I have set clear expectations. IT support in terms of, I think in my last 11 years, I finally see the DHBs, PHOs trying to work hard to get data, but that's one of the biggest frustrations we have had. And that's where I really got excited when I got one of my new graduate nurses who is an expert in IT, and I've got a very up-to-date data for my clinic where we can give you each, I'm sorry I couldn't put the slide up, I forgot actually, where we have individual ethnicity breakdown, mean average of females, males, any ethnicity, and so forth. Quite in-depth data. Standardized, the biggest enabler was for patient journey was warm handovers from doctors to nurses, because when I started, patients are still quite used to seeing doctors. So, and I was new at Greenstone, so how did we achieve that? It's doctors who'd see a diabetic patient, and I will go in, they'll introduce the patient and hand over. There were some some angry patients, but later on they have become my favorite patients, so I have become their favorite nurse. Now they would not see anyone. So warm handover, and being given the full autonomy to carry out, and trial and experiment with responsibility, not being told off because something hasn't worked. Because if it hasn't been done, it hasn't been worked anyway, so we have to try. So I didn't feel the pressure that, oh, if I do this and it doesn't work, what are my bosses going to do about this? Because it was the whole team. It wasn't just my work. And the trust from the doctors that a nurse can do this. And Tana, she's unfortunately retired from Greenstone, and we miss her. But Tana, you'd get a patient in the room, and she has diabetes, and she'll come and grab me from the room, and she'll just say to the patient, look, I don't know anything about diabetes. She will tell us what to do. That sort of statement comes from our doctors. But at the same time, if I put my hand up, I want to do this, it does become my professional responsibility to take up some professional development and education and get myself competent to do this. And I've attended lots of after-hour sessions and things like that. So getting back to what we actually do now, so the standard 3 monthly regular reviews if patient needs it. We have 30 minutes appointment with nurse. We have appointment system. So our reception knows, they know if the patient's found, I'm founding to make an appointment with nurse Devika, they know it's for diabetes, or I also do COPD, CHF, and other some of the other LTCs, so they know to book with the nurses for half an hour, and we have procedure on MedTech for them to choose. So that's a basic routine appointment. For any new diagnosis, we make 1 hour appointment, and then follow-up appointment in 1 or 2 weeks, because like we said, it's a huge diagnosis, it's a huge news for people. It's normal for us to say you have diabetes, maybe, but it's not normal for a person to find out. It's a life-changing moment. So that's why we try and follow them up in a week or 2. And then that would be new diagnosis. Also, insulin initiation will be 1 hour, which I mentioned in the case study, and follow-up appointment in person in a week. And then based from there, depending on what we give, I give options to the patients. So it's like shared care plan. We make a plan. If they want to do it via email, manage my health, phone call, drop the blood sugars in the clinic, we do it, they choose. What are in the process, we are still learning. We got lots more to do, but one of the successes we have is each of the nurses at Greenstone, we get 4 hours per week paperwork time with no interruption as much as possible. That's to go through our nurse-led program model, what we are doing in overseeing prioritizing, basically analyzing. It's like a project management. For me, what works, every morning I spend about 30 to 45 minutes. I have an active recall list. Now, I don't use any fancy IT programs. I'm from Fiji. I never touched a computer till I came to New Zealand. I only knew books. So maybe that's a good thing. So I'm trying to keep everything in medtech. So I use a lot of screening templates and recalls. I spend 30 to 45 minutes daily going through my recalls for the day. It simply says diabetes recall, and I have little notes in there. So some patients, I would found them, if they're very stable, their health literacy is good, their HbA1c is in the 40s, okay, you do for prescription, you're not due for any bloods, do you want us to do the prescription or do you want to come in? So depending on what they say, we'll do that. And then if patients do need bloods and come in for a review, so I've timed it 3, and that's again learning because it's giving them time. So we send off the recall 3 weeks prior to their medications, when their medications will be due. We are trying to save them coming in, then we give them a leave form. Then if the results need to be discussed, they have to come again. So we're trying to keep them together. So the patients are quite well-versed with that. Some of the templates we have created to try and keep, because diabetes is a multi-organ disease and there is so many things to cover. So in the last few years of doing diabetes, we have tried to come up with simple screening templates to keep a track record of things like photo screening, food check. This is on insulin initiation. Again, this is just all medtech, if you can see, as you can see. An insulin review template. And this is the template we use to do our consult. So every time we see a patient for diabetes or their review, we do this assessment template. This is a free texting keyword template. It's in a table form here, but all on medtech in F12, we just type .diab and the topics flow, and then you fill the information there. So based on this, and then I try and write these notes before I go and grab the patient, so I have a brief idea rather than looking at the screen all the time. And my new graduate nurses and second-year nurses have been doing this, and they're really enjoying it because they have a framework to work with. So that's what we are doing at the moment. We still have like about 10, like that HbA1c over 100, and like I said, we know them in. So we are trying to see what different we can do. So I have a 36-year-old, lovely Maori female who has 3 children, and her HbA1c is 146. That was last in September. Now, she would have spikes. She will improve it, then she'll go back again. And we have tried to be proactive to give, just do her prescriptions rather than her phoning, because she always has financial issues. She is now working for the last 1 year, more than 1 year, 18 months actually, at Te Hoanga at a preschool Monday to Friday. So she doesn't have time to come into the clinic. And she's also, she also gets just frustrated with the whole thing of diabetes and how she feels. So just last week, I met her opportunistically at the clinic, and we have been talking about this, but she hadn't been answering her phone. And we have offered her for us to go down to her workplace in Manirewa during her lunchtime and stuff like that. So she's agreed, and she's quite excited, and she did ask for a leave form from me. And she said once she's ready, she does a blood, she will phone us to let us know. She doesn't want me to come in uniform or with any name badges, because she doesn't want her colleagues to know. So I said, we'll come in as a visitor. And there is a team of 3, one nurse practitioner, 1 doctor, and myself. She's mostly seen. So we have given her the opportunity to just tell us whom she wants and feel comfortable, whom she would like to visit her at her workplace. Hasn't happened yet. It was only last week. On that note, I'll let Tana take over.
So, just stay here for a second. So Greenstone Family Clinic has a population health approach to care, as Devika mentioned, and we developed it many, many, many years ago. And we really didn't care about credentials. We only cared about who had the skill set or the interest to look after a certain cohort of people. So the diabetes is a natural one, and the heart failure and the asthma. But we also have an osteoporosis clinic. We have a palliative care team in clinic. We have a eczema clinic for all those kids that have eczema that ended up in hospitals. So we have an eczema clinic for kids. And we even, I mean, if we saw a condition and more than 5 people had it, we felt like it had to be led. And so we got a little bit crazy about it, but even people on isotretinoin and acne, we go, hold on, we've got a lot of those kids. So we run those clinics, the nurses, and if you're a Net P nurse, you're assigned to some cohort of patients that you're going to lead and look after. And our Best for Baby and our pregnancy register was started many, many, many years ago, and we had the highest pertussis immunization rate in the country. And that was led, changes different times as the nurses change, but that was led by a Net P nurse. So I remember getting into a discussion with somebody at counties about giving me a hard time about, I was talking about, I think it was palliative care, and they were saying, you know, it takes years for, I said, it doesn't take years for anything, actually. You have to get over that sort of mindset. I have a Net P nurse managing the palliative care patients. And he was really mad at me in some ways, like he didn't quite believe. I said, look, if you have the passion and you have a little bit of skill, you can really take on just about anything. And I think this is the thing that's changed, how you feel about it.
I think the important thing I missed, I'm sorry, is I had the confidence and the support that my GPs will always support me because we have just-in-time teaching. So I'll see a patient and I'm not sure, I'll just go to Tana and say, Tana, I know this, I've screened this, but I'm not sure what to do. So my GPs were actually my main teachers when I started. And we have open door knock policy. So if a nurse, we can go and knock on the GP's door, whether if they're in consult or not. And the rule is we should not be waiting for more than 60 seconds, otherwise the GP will be in problem. So they need to come out of the room.
So not everybody likes to work at our clinic, by the way. So there were a few criteria. If you mind being interrupted, you will hate working at Greenstone because everybody's interrupted all the time. Bruce and I started the open door policy in 2002, actually, and it was to make everybody smarter about dermatology. And it was so effective. It was knock on the door, grab your doctor and doctors and nurses and whomever, and 6 people pile into a patient's room to have a brief discussion, usually 120 seconds, about a rash. And Bruce and I it was such a successful program that we actually wrote the definitive teaching module for the medical students at the university because everybody got so smart. So knocking on a door and having a discussion for whatever it is the power really behind this. Now I'm going to go to the short piece, which is what Alliance Health Plus is doing. So we have 38 practices, and none of them necessarily are practicing like this. So we decided to try to figure out, Pauline, who's the nurse lead, and I decided to figure out what are we going to do about those practices. By the way, it's their home that we're trying to get into. You know, we're trying to knock on the door and say, we want to talk to you about your diabetes management. They're not always that happy about a PHO coming in to talk about it. So we decided to look at 10 indicators, the 5 indicators that the Metro Auckland is looking at, but we thought they're all the same. We're going to add them all together. We'll probably add uric acid to this. So we have 10 indicators. What's 5 more? And we now have a data system where in real time that changes every 10 minutes. So a practice can press on a button. Do we have this up? They can press on a button. See this, isn't this great? They can press on a button in real time and know how they're doing on those 10 indicators. So practice one, I'm going to tell you very quickly, I've gotten into practice one. Practice one is a corporate-owned practice. The GPs are not stable. They are locum GPs coming and going. Who runs their diabetes and their CVD stuff are 2 nurses that share a role. So I was able to get into those nurses. And this shows you the breakdown in the total number of diabetics and the Pacific and Indian, high Indian population. And you can see on the lower what their percentage is doing. So we've gone into these practices, and we have a little bit of a template and asking them, what is your model of care? What is your leadership model? How would you describe your leadership? Then what are the tools that you think you might need to use? I mean, really simple, basic stuff. And it's really so interesting to see what they're now coming back with. So this is us getting in the door, reminding them how to look at their data and how to analyze it and see what they're going to do. So that's practice one. We'll go to practice two. Practice two. Practice two has a very high Pacific population. Practice two has a dedicated nurse and a dedicated community worker. But the dedicated nurse only spends 2 days working on diabetes. They also have a GP who's part of that team. So they have a 3-person team. And they are desperate to figure out how they can make things better. And they have, yes, the nurse and the community worker can get into TestSafe. These are the things we're trying to ask. Get into TestSafe. Can they make e-referrals? Do they have the tools to work with? So that's practice two. Practice three, if you scroll up, it's pretty hilarious. So practice three, I have to say that I just got in the door. I considered it the biggest win that the PHO had ever had. I left and came back and told everybody he was adorable, the GP. And I had to figure out a way to change the perception of the general practitioner. It's a GP-centric practice. He sort of has a little bit of a couple hours of a nurse. Did you hear me? A couple hours of a nurse. No appointments made. And right before I had gone in, somebody had just presented with a heart attack. So I came back to the PHO and said, I thought he was adorable. He was so caring. And they're looking at me. I said, and I want to tell you, if you're walking by and having a heart attack, definitely go see him because he will save your life. I don't know if he's going to do so well with diabetes. So he was extremely defensive when I went in. And I showed him this on a piece of paper, although he can bring it up on his computer if he has the foresight to do that. And he took one look at it, and he goes, I'm a terrible GP. Look at those figures. So I felt like that was probably a real win for us. So this is early days. We just started this a few weeks ago, so I'll let you know what's going to happen. But real data, letting people see it, see how it changes, asking them what their models are, how do they operate, and do your nurses have the power? Oh, by the way, do you have a nurse? Start with that one. And do your nurses have the power to do what it takes to manage any condition? So this is a project that we're going to continue, but I just want to shift if I can. How's my time? We're in good shape. So the third thing I wanted to bring to you was a bold statement, a bold message. This is 2020, and I'm thinking about 2030. Where's the future? And I have to say, you have to look around this room because these are smart, loving, caring people here. And you have to acknowledge, though, that we are finely tuned bureaucrats. I say that in the kindest way. So I was reminded yesterday about what would Jeff Bezos say about the state of diabetes care and long-term condition care in New Zealand. What would Jeff say? And I really started to think about that. And I'm speaking like Jeff Bezos, which I think it's hilarious, but anyway. So I decided that we should take a Bernie Sanders approach. If you're watching any of the political goings on in America, Bernie Sanders is an old guy who's managed to recruit all of the 20-something-year-olds, and he's gathered them in such force. And so I think Jeff Bezos would say, bring those 20-year-olds into, galvanize that group, and make them consumer doctors. Let them medicalize their smartphones. What did I do with mine? It's just seconds away. 20-something-year-old, medicalize your smartphone. The attachments, the imaging, retinal screening, ultrasound, Dopplers, measuring your blood sugar, your blood pressure, your pulse, your ECG. Track and track and track everything. Remember, 20-somethings. And then you're going to have blockchain or some chain that's going to gather up all that data and store it and share it and shift it around so that we really know what's happening. And then I think Jeff Bezos, and I'm going to say this very carefully, I mean well, I think Jeff Bezos would say, for heaven's sakes, you have to change the diabetic medications so that they're not third world country in a fully developed country. You need first world medications, and I can tell you that that's what Jeff Bezos would say. And those medications would be end up in your pocket somehow. So I'm going to suggest that in order for Jeff Bezos to be able to do all this, that when the student is leaving high school, you're going to make sure that they're directed to Dr. Schmoodle Noodle Google and with a definitive, really excellent medical system and pathways that anybody, a 12-year-old, could follow. Each student should receive a smartphone with all the attachments so that they are truly the consumer doctor. And then I'm going to suggest to the planning committee, invite them in 2030 to be your audience and see what they did with that power, because that's where we have to get. So take a walk, climb a mountain, help a friend, but please jump into the future. We can take some questions, but I don't. No, I don't have.
I mean, what can I say? Fantastic. But I would like to say, and it's an opportunity to just say, firstly, a huge thank you. Talking of, I mean, that's just blown me to the back of the room, actually. But talking about Greenstone and talking about the support that's been provided, this is not a question, this is a comment. If ever you want to get an amazing therapeutic experience, you need to walk into a place like Greenstone. And I speak from another PHO perspective in that respect. It is an incredible place. You know, you can't get it from a subsection of Cornerstone or of a policy manual. It has a special vibe to it, and it's an amazing place. Helping to build workforce capability outside their organisation is commendable, and they've been doing that, and they continue to do that. So it's a huge thank you to Tana, to Alliance Health Plus, as well as other PHOs that do support that we are all in this together. So thank you very much. Superb.
Thank you. Any other questions? Go, somebody go.
Thank you for your presentation, and I think that we're all amazed at the work that Devika does in the practice, so thank you, Devika, for that as well. I was just interested that you took this example and you took it out into other practices. And I was just, I've been reflecting for a while what a wonderful resource it would be if we had some visibility across our practices to know, which practices were practice ready, which weren't, what resources do we need? Can we work as a team with the DHBs and the PHOs and really, look at what our needs are to make diabetes work for our people? And I guess it's a plea for integration, and it's a plea for information sharing and maybe a stock take of our practices. Thank you.
Thank you, Sue, for bringing that topic up. We at Greenstone have had quite a number of requests from different clinics for their nurses to come and sit in with us or observe our clinics, and we are trying our best. And like you said, there is no structure, there is no framework to do this, and we have supported 3 clinics so far where a nurse comes in and sits in with me for 4 hours, and not just me, we have had other nurses or aspiring nurses wanting to be nurse practitioners. They come and spend time with other nurse practitioners and so forth. So, but there is, like you said, there is no kind of proper framework around this.
And as a PHO, I have to tell you, while we are responsible for the practices are, by the way, completely independent and can do their own thing. So when you open their door of their house, there's a certain sense, all the while, you're there because of criticism in some ways. So you have to really exercise a lot of caution and carefulness and I was trained many years ago in a slightly different profession you always have to find the positive. And not that I'm Pollyanna, mind you, but so when everyone was laughing when I was getting ready to go to this clinic with this GP. And when I came back and I said, I thought he was adorable. And they were so blown away by me saying that. And I think it might help, actually, for the further visits, because we have to shift some way. And, it's a minor way. Yeah. Who?
Really, just a touch on it, and just very warm congratulations. And just to acknowledge the inspirational value of the presentation. And just the drawing together, I think, of so many threads. The really human element, where particularly I was just so struck by that conversation about making arrangements to go out to the workplace and not go in uniform and so forth. So a very, very human angle, but then also the challenge around getting smart with technology. And we heard earlier in the sessions about the fantastic advances that can be made with Libra and how that puts someone in the driver's seat. So, that's sort of resonating as well.
Jeff Bezos would love that.
Okay. And then also just putting it out there, the challenge around where the medication should be at. So I just want to acknowledge the drawing together of all of those threads, and thank you very much.
Thank you. Yeah. Thank you all very much. It's really fun to be here. I've been coming here for many years, and I really love to be here. And I love all the different voices, and I'm always inspired. And so I really treasure it. Thank you.